Dr. Ugwueze, thank you so much for taking the time out of your busy clinic schedule as you are still at the hospital to meet and chat with us a little bit about global IR and some of the lessons that you've learned and kind of dedicating your life to that pursuit. Before we dive a little bit into like what global IR is and some of those lessons that you've learned, I was hoping you could just start us off by telling us a bit about your background and how you found IR to begin with.
All right, thank you so much, Alden, for this invitation and for having me on the podcast. Um, as you mentioned, my name is Dr. Chidubem Ugwueze. How I found IR, actually, I went to med school at USC, Keck School of Medicine, and in med school, we had regular free lunch talks where student organizations like hosted like interest groups and they get free food. And I went for free food one time, and one of the talks was a talk by Dr. Vatican Cherry from Kaiser LA. And he talked about IR, and after that, I was like hooked. I went and like got his number. This was like within a month of med school, like this was like first or second month of med school, and I started shadowing him in clinic. I shadowed people at USC as well. I was still kind of wanting to do surgery for a while, but then my third year, it was like clear that IR was just so much more fun for me, both as a balance for like technical skill, like variety of cases, and also I kind of also liked the DR a lot as well. And the balance between having DR skills and IR skills seemed like just a good balance for me.
That's great. Yeah, the free lunches as a medical student definitely are a pretty easy way to get us there. I was also lucky enough to have an early experience into IR and definitely, as an early med student and you're just still learning basic anatomy and physiology, getting to see some of the things that you guys do in the angio suites is pretty captivating. So I can relate to that. Um, so you find IR, you get excited, you think it's cooler than surgery in some ways. How do you find yourself in this kind of world of global IR and getting through residency and now as an attending? Like, how did you find that? And if you could also just talk about like how the general tenets of global medicine relate specifically to IR, or kind of some of those issues that came up as you started practicing outside of the States.
I will say I found global health before I even found IR. So like before starting med school, I knew. I grew up in Nigeria. I was born and raised in Nigeria. I moved to the States as a teenager, and I've always had the inkling that I wanted to go back home and help out at home, and I didn't know what capacity that was going to be in. When I then decided to become a doctor my junior year of college, I did a master's in global health, kind of like in preparation for that future career that I wanted to have. And like when you're talking about global health, I'm specifically referring to like global health equity, which is the idea that we should remove all barriers to for people to have equal access or equitable access to healthcare based on geography, politics, and like finances, or just the like generalized socioeconomic factors that affect access to care in general. I did the master's actually when I decided to do IR or was thinking about doing IR. A significant number of people who knew that I had a very strong interest in global health discouraged me from doing IR because there was this idea that IR is one, it's fairly new specialty, two, it's like capital resource and like just resource intensive specialty. And there was a kind of like the understanding or the not the understanding, but the conventional wisdom at the time was that if you want a career in global health, you should probably do like infectious disease or internal medicine or something or like general surgery or something in those lines, that it will take a longer time for IR to have more global prevalence. Um, I In addition to liking IR, I took like personal offense to that. Like I literally like felt like it's just like disrespectful for someone to believe that in my lifetime that someone in a place or similar to a place that I grew up in won't have access to like high quality um, image guided therapies. So like I took that as like a personal challenge to bring that to if I was accepted as an into IR residency or became an IR, to bring that to um places similar to where I grew up. Now that's how I kind of got into this path. My experience so far, as a resident, I did a lot of global health work. I started the RAD8 chapter at my residency program. And I work with the RAD team in Nigeria to do several outreach projects. The most notable one being an IR symposium at University College Hospital in Ibadan in 2019. That was when I went with a team of five IR attendings, two residents, several nurses and techs, and we did lectures, live cases, and had people from around the country come to kind of get exposed to IR. And also, that process was when I kind of learned firsthand that people in Nigeria were already actively teaching themselves, going out of the country and learning these skills at minimum, the like non-vascular skills, to kind of bring uh, image guided therapy to their people already. With now our role was to help them augment those skills that they've either taught themselves or have learned elsewhere, and help them like capacity build, both like human capacity and like actual um, imaging capacity, to kind of get these skills and services going. So that was the beginning, and that was my beginning as a resident. Uh, I slowly graduated also as a resident to helping Dr. Ahmed Ninalowo, who's an IR attending in Lagos, Nigeria. He was a fully trained US-based IR and has moved back completely to Nigeria and is providing the wide spectrum of IR in Lagos. So I helped him um, establish a training program where when he trained the first IR trainee in Nigeria. And now I'm helping him continue that program and spread IR practice and training to the public institutions in Nigeria. So that's kind of the general gist of kind of where it started and kind of how it's going so far.
Yeah, that's great. That's very inspiring to hear that you kind of like had this mission, stuck to it through all of your training. And I could imagine the frustration of someone setting you up to feel like you couldn't do it. But then to succeed and then not only be able to do that, but to create a pathway to create more IRs like organically in Nigeria is pretty incredible. What was like the healthcare system? Like what does that look like in Nigeria? And has that changed a lot from kind of when you left as a, young teenager and like you're saying a lot of these docs were going out and training themselves elsewhere, like how different is like what we're picturing from like an American understanding of a healthcare system to like what they have in Nigeria?
So the Nigerian healthcare system is, I'll first start by talking about like the public sector. And the public sector is supposed to be like a primary, secondary, quaternary system where there are about, the last time I counted or I checked, were about 16 tertiary teaching hospitals spread out throughout the country, and they're usually about like 1,200 or like 1,600 bed hospitals that are meant to be like the main hub referral centers for a specific region. They're supposed to be the main hub for referral for like higher care treatments, and they're also supposed to be the hub for training. So most people who do like residency and fellowship get their training at these teaching hospitals. So that's kind of the public sector. On the private sector, there are huge multinational, well-equipped, like very, very like nice hospitals throughout, mainly in the big cities in in Lagos and Abuja, where people can go and get and pay cash and like get very, very high quality care. But you have to have the like financial wherewithal to like go to these places and pay for it. And your initial question was like, has this changed from when I lived there as a teenager? Unfortunately, no. But there
Hmm.
are like individual changes, like individual people who have gone and made a significant impact by either opening up their own um, private practices, opening up their own hospitals. Um, but the public sector, and there are very like forceful efforts being made both by individuals and the government. But the public sector has multiple leaps forward and then kind of backtracking that's kind of happened back and forth over the past few decades. Optimistically, I feel like right now is a moment of many leaps forward, and hopefully we can like maintain that momentum.
So when you go, are you working mainly in this public sector? Is that where you've been like interacting with faculty and training students? Is it through that public, like those big tertiary hospitals?
So when I go to Nigeria it's hybrid. So I work with IR Doc Nigeria. IR Doc Nigeria is a private practice IR practice in Lagos run by Dr. Nina Lowell. That's where the wide breadth of IR is practiced. Like he does from body IR all the way to neuro IR as well, doing like strokes and cerebral and aneurysm coiling in Nigeria. So when I go, literally, it's usually 50-50 where I spend 1 week with him, and the primary goal there is to help him with with the fellow who's training with him, and also kind of understand and learn the lay of the land of how IR practice and just like private practice and clinical practice in the big city works. And then the second half usually is I spend it with at a teaching hospital. So my last visit, I went to the University Teaching Hospital in Maiduguri. So Maiduguri is in the northeastern part of Nigeria. The chief medical director of the hospital is an IR called Dr. Ahijo. Dr. Hija has been practicing IR in Nigeria since 2005. So he went to Vienna and did an IR training there. And after his training, he went back to the University of Maiduguri and has been practicing and trying to build IR there since. And he's had multiple starts and stops. The stops happening when like equipment breaks down and the vendors are not like robustly able to come and fix it. But now he's built a fully self-standing IR hospital within the teaching hospital that has um, space for four angio suites, two of them already installed. It has space for ultrasound. It has space for, they already have ultrasound procedure suites. They have microwave ablation capacity, CT and MRI as well. And this past September, I was there doing cases with the residents and the staff there. So the head of the department, Dr. Tijani, and the director of the hospital, Dr. Lawan, were my partners during this trip. And we did several cases. We did uterine fibril embolization. We did PAD, right lower extremity recon for a patient who had a non-healing ulcer. We had some IO cases, and we had multiple consultations that we had to refer elsewhere. But it's a mixture of doing both the private and the public. And for me, it's basically kind of understanding the lay of the land for both patient populations and just how to best serve them, and also kind of still building the capacity for training people as well.
Yeah. That sounds like an interesting balance of, like you're saying, like trying to support a training pathway and kind of creating the capabilities there for, Nigeria to grow their own IRs, like in the country, with, like you said, also trying to make sure that the balance is like distributed with kind of the average citizen and the like average people in Nigeria. Um, so in America, it seems like, someone gets a referral to an IR, and if you're living in a big city, it's not too hard to maybe get into one. But like, what does that process look like in Nigeria? Or if someone has like um, a UFI, for example, or some kind of more elective IR procedure, like how hard or how long is it to get in to see an IR? Is it mostly just cost prohibitive, or is it pretty resource limited as well?
So it's so how do people hear about it? So the how is usually like word of mouth. So it's either you happen to have an OB or a primary care physician who's aware that IR capacity is available, and then they refer you to the interventional radiologist for a procedure. Um, the ability to get a UFI, use UFI for an example, is dependent on what setting you are in. So if you are well resourced, because of Dr. Nina Noah's practice, you can go to Lagos and you can pay to get a UFI. And because of like the workflow of the private sector, the turnaround is pretty fast. So like I've seen someone come for consultation for a UFI like in the morning and like get their UFI like either that day or the next day, just because of how fast like the work through is. Like because you can get there, see the IR doctor. There's an MRI downstairs. You can go get your MRI pelvis. You can review it and either schedule you for the procedure or whenever you are comfortable with it. And because you are like kind of paying out of pocket and you're okay paying whatever is needed, that can kind of move pretty quickly. However, not most people do not have that capacity. So, and people who are going to the public institutions, what usually happens is that, for instance, um, they know someone like myself or someone else like Dr. Akinyemi, there's another IR who also frequents Nigeria, is going to be coming to the public institution to help teach and kind of help proctor cases, and those patients are then like um, brought to the teaching hospital at the time when the visiting IR is coming, and that depends on the frequency. So like for instance, myself, I went 5 times this year. So like almost every quarter, someone's available, but that's something we're trying to increase as we move on to next year. Um, but that's kind of how it is now. And then also Dr. Peter Adeniwa. So Dr. Peter Adeniwa is the IR fellow who trained with Dr. Ninalo in Lagos, and he is now back at UCH and is able to do these procedures himself at the public institutions. He doesn't currently have the capacity to do them because there are issues with power supply, like regular unstable power supply, and two, the hospital is still in the process of building him an IR suite. So he is in the interim doing cases at private institutions that have the capacity to do them in Ibadan and elsewhere in Nigeria as well. In addition to Dr. Peter, who's trained in Nigeria, there are several trainees that Dr. Ukwe, Dr. Bola, Aremu, Adeni, these are all Nigerian young and energetic IRs who've gone to Tanzania and got gone trained with Road to IR, and now they are back in Nigeria building their practices respectively and offering these services to Nigerian patients. These are the most recent people who've done these. There's a very long history of Nigerians going out, training, and coming back. The first um, angiography was performed, and the first angiography performed in Nigeria was done in 1964, and at the University College Hospital in Ibadan, which tells you that the interest, no, not sorry, not 1964, like in the late 1960s, like early 1970s, was done in. I was thinking 1964 for that's when Daughter Day
Daughter.
is first,
Yeah.
yeah,
I was
first,
like, word
yeah.
travels fast.
Yeah. Well, this has been in Nigeria since the 1960s, early 1970s, in the public institutions at UCH. However, um, like I said, we have several steps forward, and then um, things like decay, like equipment is not maintained, people are not subsequently trained, and then these skills that were procured like kind of fall to the wayside and are not like nurtured. And this time around, we're trying to do our best to make sure like these crop is nurtured and they're given the equipment and tools they need to kind of propagate this indefinitely.
Yeah. Wow. Um, what do you think has like surprised you most about getting to see IR in Nigeria and I mean getting to go back and see kind of your home country change now as an adult, but like I guess from both perspectives, like socially and culturally, but also like from the medicine side, like what do you think surprised you the most by this role that you now have dedicated so much of your life to?
Um, Two things have surprised me. The first is that similar to earlier when I mentioned that like there was like a conventional wisdom when I first made this decision that like this was not going to be um high prevalence, highly prevalent in my lifetime. Like where things are now are way beyond like my imagination. Like even when I was imagining how things would play out, um, I didn't even imagine that it'll be this far ahead at this stage of my career. Like my understanding of how things were gonna play out was that I was gonna go to residency, go become trained, go to fellowship, become an IR, start practicing in the States, maybe practice in the States for like 5 to 10 years as I build my skill and and capital to then go back to Nigeria to slowly start building things and helping. That was the timeline I imagined. What actually happened is that my first 2 to 3 weeks of an attending was in Nigeria, helping out in the IR practice in Lagos with Dr. Nina Lowell. So people ahead of me were already doing the groundwork of kind of building the capacity and proving that this is possible. I think the first step was to prove that this is possible and prove that it's possible to like practice not just like bread and butter IR, but like very high-end IR in these resource limited settings. And that has already been done. So now I feel like I have to like reset my goals and aim for something more and like kind of my initial thinking was like to be the one to prove that this is possible. Now I have to rechange and now focus on the true thing that was is the desired thing, which is like the systemic capacity building and infrastructure strengthening that's going to make it possible for not just the very well-to-do, but like kind of everyone can be able to like have access to these procedures. That's the first thing that surprised me. The second thing that surprised me is that there are so many people doing this already, like not just in Nigeria, but like elsewhere. Like there are like the Sapphire exists, and Sapphire is a society for IRs in Africa. It's already exists. I've gone to two different conferences, one in South Africa and one in Morocco, and I've met so many people doing this type of work throughout the continent. Um, as part of my role as the director of global health at OHSU, I've been engaging with people in Asia as well and kind of tapping into that region as well. And there are people doing IR everywhere. So like it's just like that brought me so much joy to see that like everyone is like tapping into this and like kind of like pushing the boundaries wherever they are. And that has been like I don't know why that was surprising to me, but like it was like a very good surprise.
Yeah, that's incredible. I'm sure it is a very special feeling to get to be in touch with such like a global community. And like you said, like, you've put a lot of blood, sweat, and tears into this, and it's meant a lot to you. And I'm sure that once you kind of like take the blinders off and like pull your head up from the water and look around, like seeing that people all over the world feel as passionate, and it's like, it's coming from places, like you said, of people wanting to help others and wanting to make sure that these are sustainable systems that are being created. So that's incredible to get to like play a role in that, not just in Nigeria and not just here in the States, but get to kind of be a part of that happening everywhere. Um, yeah. And I'm sure, especially like still practicing your part-time or like the rest of the time in Portland, the famed home birthplace of IR, that's a pretty special legacy to get to like, I know we love to talk about it and it feels special here, but then like you get to see it around the world and you're like, there are people, visionaries doing this everywhere, not just, not just
Everywhere.
here and not just there. Um, so you mentioned a couple programs like Sapphire, and then you said Rad Aid and Road to IR. Like, can you talk about some of these programs and what they are? And if a medical student or a resident or attending is hearing this and they're like super excited about it, kind of like what those organizations are and kind of what roles people could have to get involved.
Sure. So I'll talk about them starting with Rad Aid. So Rad Aid was like my introduction to global health and radiology and IR. I went to the Rad Aid conference in 2018 in DC, and that's where I met everybody that I'm working with in Nigeria. Well, not everybody, like a good number of people I'm working with in Nigeria. I met them at that conference in 2018.
Wow.
So I met Dr. Nina Lowell. I met Dr. Farouk Dako, who is the director of Rad Aid Nigeria. I met both those people at the Rad Aid conference. So if you are as a med student, if you're a resident, if you're interested in global health, radiology, or IR, that's one pathway to do that. Um, Road to IR is a training is a nonprofit that's supporting training in Tanzania initially, and now has expanded to Uganda. They just graduated their first fellow class in Uganda this past year. So if you wanted to support training in Tanzania and Uganda, you can reach out to the Road to IR team, and you can easily get plugged in to join a team going to Tanzania or Uganda. I've been to Tanzania twice, once as a resident, and this past wow, in February this year as an attending. And both experiences have been amazing, and I learned a lot. And those are like my buddies, like whether they know it or not. So like they're so those are like I learned a lot from how they operate. I learned a lot from them, and that's one avenue to get involved as a med student. Sapphire is more. Sapphire is a Society of African Interventional Radiology and Endovascular Therapy.
Mhm.
Um, it's a nonprofit that's supporting, it's kind of serving the role of something like SIR or CIRSE for the African continent. And we have annual conferences on the continent. This year it was in Morocco. I believe next year is going to be in Tanzania. Um, Honestly, if you can make it to a Sapphire conference, I would highly recommend it. Both for being able to experience the African continent at in a conference setting, but Sapphire is a much smaller conference, but a lot of people who practice in the States and around the continent congregate there. And because it's smaller, you're gonna get way more face time with these people at the conference than you would if you were like at SIR or Cersei. Um, and then you get to come to Africa. Like
Yeah.
Uh, and then the last, if you wanted to specifically go to Nigeria or Ghana, I just recently started a nonprofit of my own called Advancing Interventional Radiology Alliance, so AIR Alliance. And we're going to be focusing on sending teams similar to the mold of Road to IR to support IR training, capacity building, infrastructure support in Nigeria and Ghana as well. So, and then just reach out to myself via email, or just find someone at your local institution who has experience with these things, or interested in getting involved in these things, and they can be like your champion to kind of get this started at your local institution.
Yeah, it's crazy how powerful networking and connections are, and like you said, that does sound like a pretty awesome experience. Not only just to travel and get to see parts of the world, but get to, meet these people who are kind of taking IR to the next level from all over the world. And I'm sure it's pretty wild to get to see um, the ways that people think about the same problems differently based off their cultural context and the resources that they have. And everyone's just MacGyvering up a solution to the same problem. So exciting to get to see how it all kind of comes together. Um, what sort of lessons about medicine and then maybe like life as a whole do you think that you've learned from getting to do this type of global IR and global medicine that you might not have if you just were hanging out here in Portland, Oregon all the time?
I'll say the main thing is just it really strengthens your capacity to be adaptable. I think that like that my experiences in global health and working in Nigeria, working in Tanzania, um, have really kind of reinforced to me that like the primary trait to like be successful in life is that you need to be like flexible and adaptable to like different situations. It might sound cliche, but that's kind of like what I'm like taking away from it. Um, not sure if that fully answers the question.
Yeah, no, it does, and I think IR specifically maybe is a field that I think cultivates that or maybe calls people to it who like the challenge and the opportunity to adapt. No, that's great. So bringing things a little bit closer to home, we live in a place where almost all of our country is rural, and most of our populations don't have access to, the big academic level one trauma centers. What parallels do you see with practicing global IR and rural IR? And what have you learned kind of by doing this and helping start and strengthen these structures that we could apply to some of these, places in our own backyard here?
That's a very good question. I think the first thing I would say is that there is a instinct or desire when you're either doing global health or doing coming from a urban area and going to a rural area to try to impose yourself or to kind of impose and dictate what you think they need. I think the that approach just doesn't work. I think the primary focus it should be building with the community and for them, which can take different shapes. It can mean in like the global work that I've been doing has been primarily focused on like human capacity building and like training people to do these things themselves. Um, in the States, that could be potentially one way to do it, like kind of reinforcing that like primary care physician, internal medicine doctors still need to have those skills to do like the basic like paras and thoras, and not have patients have to travel very, very far and get transferred to like a tertiary hospital like in the urban area just to get such a what we deem as straightforward. Um, procedures. Now, like there are nuances to that in the sense that like there are um, limitations with like getting like privileges for doing these things, but like there could be a drive to kind of help people get these privileges, and at least for those um, more straightforward, simple procedures, so people to have access to them in the local area. The other way to do that is like similar to how is to kind of streamline and instead of focusing on like maybe doing like having people go do locums for a short period of time, kind of find a way to have more infrastructure building where there's like a it's not like a one-time fix for these things, but like training people who desire to go back to those areas to practice. Or having a more robust transfer system like we have in Oregon, in Portland, where we have very, very good, robust systems for transferring patients from rural areas to more tertiary institutions that have IR capacity in Portland from all around the state. So those are kind of things that can be applied to the from rural to from global to rural in the U.S.
Yeah, I think it's interesting too to think about like awareness and sort of the idea, like you were saying earlier, like how do people find IRs and like do family medicine docs know where the nearest IR is or what even services they offer? And it makes a lot of sense what you're saying that if someone just shows up for a weekend and does some cases, that's not going to do anything to like build longevity of care for that community. But it's something, I think about a lot. And kind of like you said, I've been told by a lot of people that if you want to live in a rural place, IR looks real different. And like maybe you're not doing very many procedures, you're not doing fancy procedures. And, I kind of want to push back on that too, just knowing that like, the technology we have for imaging is becoming so ubiquitous that it's like, you can do a lot of stuff with an ultrasound. You can do a lot of stuff with CT scanner. You don't need all of the fancy stuff. So I'm excited to kind of see how, like you said, hopefully there can be an emphasis maybe on creating those resources, but excited to see how that changes in the coming years.
I'm
Um,
gonna add two things to that. So yes, you can do a lot with ultrasound. Yes, you can do a lot with CT, but a lot of the time, these rural places have the capital equipment. They have a C-arm. They have an angio suite. It's just they don't have the human capital, the IR physician, to be able to do the procedure. So one way to do that is to kind of help them maximize the utilization of the equipment they've already kind of acquired. And then something that I should have mentioned earlier, but is that like we also should also pay attention to the socioeconomic reasons why these patients are waiting for a long time to seek help and like the reasons why these patients are making these decisions like they're not it's not when you look at it from their standpoint sometimes these are not irrational decisions if you're choosing between having to pay to go to the hospital versus eating like that's like a that's quite reasonable thing to like understand that we also have to factor in like access to health care and health insurance and able to pay for these care as a bottleneck for all this problems that we're having.
yeah, it's one of the hardest problems to solve. And, as clinicians to be, we spend a lot of time learning medicine and learning the craft that it's easy to kind of put your head down and not think about those things, but it's so important, yeah, to start understanding like when you order a test or you offer a procedure, like what does that actually mean for the patient and like what impact on the rest of their life is that going to have? And I know that was like one of the kind of pulls to IR to me is, seeing like if you can do a procedure for someone and they don't spend a week in the hospital, they spend a day in the hospital, and suddenly that person isn't paying, astronomical prices to be admitted for a week and everything that comes with that. Doesn't change that, an IR's time is expensive and the disposable equipment is expensive, but it almost seems to me that like, yeah, in these underserved communities in these like under-resourced communities that having an IR rather than a general surgeon almost seems more effective in being able to provide healthcare to these people who may not be able to afford, a hospital admission. But again, the nuances of who makes those decisions and where that money comes from and goes is for sure over my head. But good
I
stuff to
would
think about.
you still definitely 100% definitely need general surgery. They should
Yeah,
not go away.
yeah.
Um, but like the point that you're bringing up that like the recovery time um saves patients like long hospital stays, but it also allows the hospital to treat more patients. Like if you're having a more rapid throughput through the hospital and people don't have to stay for longer recovery, then you have more bed availability for patients to be seen in the hospital, and that's a huge problem because we sometimes we're trying to receive transfers into OHSU or legacy system here, and we can't because the hospital is full. So if you're able to kind of decrease like the hospital stay in like shorten length of stay, that can also be a way to kind of improve access as well.
Yeah, that's great thinking about it too on that level of a big American city, like having those kind of same problems of access and the same problems that we kind of face globally. Um, so kind of looking forward, what do you see as the future of IR, both like domestically in Nigeria and just globally as a whole? Like where do you see things going?
I think the future of IR is like very bright. Every time I interact with like med students like you guys who are like very enthusiastic and like um, full of energy, like it like buoys me and like gives me energy to keep doing what I do. I think things will continue improving both in innovation and also as we get more data and support for the procedures that we do. It'll be more, it will continue to get widely accepted as it already is. Um, the the question now is like just how ubiquitous can IR get? That's kind of the question now in my mind. I think we're here to stay and the future's very bright.
Great. I agree, and hopefully I'll get to be a part of that in not too long. So kind of in respect to your time and getting ready to wrap things up, what do you have any messages or anything else you kind of like to leave us with before we close out?
I'm biased, but I think IR is the absolute best specialty ever, and I think every med student should want to do it. I don't regret ever choosing this specialty. Like it gives me so much joy and fulfillment in life. Um, but I would just say that whatever specialty or whatever you choose to do, I say do IR, but always try to balance it with like having a nice like work-life balance. Not work-life balance, but like work life fulfillment where you're getting fulfillment from things outside of work as well. So not just working all the time, even though I'm not preaching that right now.
I was like, as you're sitting in the hospital, but yeah, that's, easier said than done, but it makes the whole process a lot easier from the medical student and trainee perspective, seeing attendings like yourself who still have a lot of passion for what you do, are a genuinely happy person, and so it means a lot that you have taken time to kind of mentor and get involved with us at this level because a lot of that energy stems from seeing people like yourself doing incredible things both here and on the global scale and getting to interact with people like you that carry that forward and exude that, make it a lot easier to get back and hit the books and get excited about residency and the road ahead. So yeah, I just wanted to thank you again for taking the time. I enjoyed our conversation. I think all the listeners will, and hope to maybe see you in the Angio Suites at Legacy sometime soon.
Of course. Nice. Hopefully I see you around or at the VA or at the U,
Oh,
or at HMC. I'm everywhere.
we'll be there. Awesome. All righty. Well, thanks again.